everyone. I'm Leigh, as she said. Today we're going to be covering hip and knee osteoarthritis. So questions hopefully will be answered throughout. If there's anything that I didn't cover, we have a page at the end that will be going over any questions. So I just ask that you write them down in the meantime, and hopefully they'll be covered throughout the presentation. All right? So, what is hip and knee osteoarthritis? Arthritis generally refers to and literally means inflammation. So although that's more of a sign or a symptom, it's referred to as a diagnosis to anything that's really causing inflammation within the joint itself. It's mostly affected in the knee and the hip because those are our primary weight-bearing muscles, although any joints can be affected by hip and knee osteoarthritis. So specifically, osteoarthritis, as opposed to regular arthritis, refers to a wear and tear of the cartilage within the joint. And cartilage is the slippery tissue that covers the ends of your long bones. And over time, the wear and tear and the compression of those joints will cause that cartilage to break down. So basically, the causes bone-on-bone contact and those to rub together. Over time, the bone-on-bone contact can result in bone spurs and bony abnormalities in the joint itself. So if you refer to one of the next slides, I actually have pictures, and it shows both the hip and the knee, what a normal healthy joint would look like as opposed to one that has been formally diagnosed with osteoarthritis. So if you want to look at the hip or the knee, you'll notice regular ones are on the left. On the right side, you can see that some bony abnormalities have grown on the second one. Sometimes those bone spurs can chip off and go within the joint space itself, and it can lead to extra cartilage or even the bone itself within the joint, and that compression alone can result in the pain and some of the symptoms of osteoarthritis. Who is most affected is often the elderly. So one of our risks is age. It increases as we age just because over time that's a lot more wear and tear than when you're younger and you're running around and you haven't had that much damage done to the joint itself yet. But younger people can be affected by it. It's just not as common. So arthritis is one of the leading causes of disability in the United States. It's most common among other people with chronic conditions. So you can see that almost half of adults with heart disease or diabetes have arthritis. So that's a pretty significant amount. When we also go over risk factors, you'll notice a lot of those risk factors are very similar to risk factors for some of these other chronic conditions. So not only by trying to reduce some of those risks, you can not only reduce your incidence or slow the process of developing osteoarthritis, but also some of these other chronic conditions, which are pretty significant. And 31% of adults who are obese also have arthritis. So if we go on to risk factors, who is more at risk? So like I mentioned, one of the biggest ones is age. So it increases with increased age. Individuals who are obese or overweight. Am I going out of order?
No.
Okay. I see a lot of flips, so I just want to make sure that I'm not missing anything. So obesity and overweight is also a risk factor for developing OA. You're more likely to get arthritis, any form of arthritis, with the amount of weight that you have on versus people who are underweight or even of regular weight, because excess weight can also put more stress on the joints, but also because our hip and our knee are our weight-bearing ones, like I mentioned before. So obviously the elbow is not going to get as much damage done to it if you're not putting as much pressure through the floor or constantly putting your body's weight through it. Anyone with a history of fracture or joint injuries also are at risk for developing osteoarthritis. So previous history. Sometimes I see a lot of people who come into the clinic and they're like, yeah, I had this injury way long ago, but it kind of resolved itself. I've kind of had a little limp ever since, but it's never really given me an issue, and now I have this diagnosis of osteoarthritis. Well, some of that can play a big role in it. If you never got back to your full function from that previous injury, then maybe you're walking around differently or moving differently or have developed different movement patterns that are considered the normal movement pattern or your body's normal movement pattern. So that can just predispose you to developing osteoarthritis by putting more stress on certain parts of the joint, maybe not as much on the other part of the joint. And that's not to say that the whole joint itself can be affected, but certain times you may feel it more in one spot versus the other, depending on how severe the cartilage damage is in one part of the knee joint. Does that make sense?
Yeah.
Okay. Occupational or athletic overuse, so repetitive movements. Over time, that's a lot of wear and tear in one spot. So if you have certain movements, like you walk a lot, or you're a runner, or you play tennis and you do a lot of pivoting, or pickleball, which I've learned is really popular in Sterling. A lot of that repetitive movement with the lack of strength can develop, again, different movement patterns, which in turn can also increase your risk. That also plays into posture and joint defects. Sometimes those are hereditary. Sometimes people are born with their hips in different positions. There's something called congenital hip dysplasia, more often in women than men, just because of the way we have childbearing hips. So ours are a little bit bigger, and that causes our femurs, our thigh bones, to be placed in a different position. And that stress placed on the knee itself, or even in the hip, can make a difference on where the stress is placed in the joint. So just knowing or being mindful, was I born with any birth defects that have been affecting me? If that's the case, and it wasn't resolved previously, just like other previous injuries, that can also increase your risk for developing hip OA or knee OA. And that could go in the opposite direction too. People who are hypermobile or double jointed, we refer to it as, that ligament tension can also, again, cause those movement patterns. You'll see all these kind of play into each other, right? Different movement patterns, more repetition, more stress placed on one certain part of the joint. Gender, bummer women. More likely than men to develop hip or knee OA. Like I said before, that could probably be due to postural positioning or just body mechanics in general. It's just the way that we are born. It's just kind of stinks for us, huh? What the heck? You have to bear a child and develop hip OA?
Yeah.
I know, right? Going back to posture, again, the positions of the hips too, that doesn't have to be something that you're also born with. That can develop over time with certain movement patterns. You might develop tightness in one area and weakness in others, and the imbalances between the muscles that surround the joints itself can cause your posturing to be in a different position at rest. So I'm going to stand up and demonstrate what a neutral position is considered as. So if I stand here, I have my good posture. This is what's considered a neutral position. A lot of times we have muscle imbalances from things that we do on a day-to-day basis that maybe we favor one side versus the other, or we have habits or occupations that require us to do things in certain motions over and over again. and things can become tight, which can cause your bones to be pulled in certain directions. So a lot of times I use the example of your hips. If your hip flexors are tight, the muscles that are in front of your hips, when they shorten, they will pull your hip bones, and you can end up with a position where you have a larger arch in your low back as opposed to your neutral position. So if you develop some of these postures and you're standing in certain positions or moving in certain positions where things aren't in a neutral position, then you're kind of at a disadvantage just to developing not only more joint stress, but also some of the ligament and tissue stress to muscles that surround the joint itself. So it's kind of a cycle of things. You know, you want to address, well, what actually caused, you know, the development of this? It's likely cumulatively all of the risk factors, but you want to take a look at, well, how am I moving? How am I standing? Is my standing posture considered the normal standing posture? Or do my feet slightly fall in? That's another thing that we see in the development of more so knee and hip OA is foot posture. So a lot of times, over time, the muscles on the bottom of our feet that support our arches, they weaken and they collapse, which causes them to fall inward. So a lot of times, you see that what that did to my knees? I started in a neutral position. I've got neutral arch. If my arches fall flat, which they do, and I wear orthotics outside of here when I'm not wearing my flats, my knees will have a tendency to buckle inward or fall inward. So that will place more stress on the inside of my knee more than it will the outside of my knee. If I start to develop pain on the inside of my knee, well, that could be because I'm constantly having stress be placed between the bones of my thigh bone and my shin bone. Does that all make sense? Yeah. A lot to think about, right? But you can come on to All Access PT in Sterling and we'll check out your posture for you. So what are the primary symptoms? What are you expected to feel if you have a formal diagnosis of hip or knee OA? Well, the primary one is pain. Pain and swelling may be worse in the morning or after periods of prolonged sitting. Maybe when you're sitting for a while and the first thing you go to stand a lot of times. That's when it's worst, after like a long period of rest, and then all of a sudden your muscles are stiff, the joint is stiff, and then you all of a sudden go to move and do a large movement. That's when you'll end up feeling pain. So swelling and stiffness are also kind of hallmark signs for OA, and those two can lead into a reduced range of motion or lack of your full range of the knee and the hip. So maybe going downstairs is difficult, going upstairs might be challenging, even sitting and standing, periods where you end up being stiff for a while and then all of a sudden the joint has to move to an extreme range, or what the joint considers extreme. Locking and sticking are some also signs that indicate OA. And again, that's also as a result of the stiffness, swelling, which will limit that range of motion because it doesn't have as much room to move freely. But it could also be loose cartilage fragments or the bone spurs within the joint itself, creating that catching motion because it's not moving as smoothly as it was prior. Sometimes a feeling of weakness or buckling will result because of that. So there is some evidence also that people with arthritis will notice an increased joint pain with weather changes. A lot of times that was referred to as a myth, but now they found that changes in barometric pressure can also change the pressure within your joint space. Like we already know, all right, I'm stiff, I'm swollen, there's not much room for it to move already freely. Let's add some weather on top of it and take away some more of that joint space, making it more painful and probably difficult to move on some rainy days. I know. The good news is we have changes for it. All right, so diagnosis. Doctors will normally use a variety of methods to diagnose mostly to rule out any other sort of pathologies that may be pre-existing. A lot of times we don't just have a nice simple knee or hip OA. A lot of times there could be other damage within the joint itself. So it could be ligament damage, it could be cartilage damage, it could be soft tissue or muscle or the tendon that surround the bone itself. And a lot of times they'll choose that method of treatment going forward based off whether other pathologies may be existing. Primarily, your doctor will use history, signs and symptoms, they'll look at risk factors, and then make a clinical diagnosis, mostly based off what you tell your doctor. Then they'll start with an x-ray to rule out any other sort of fracture or bone damage within the joint itself. So I have a picture that shows an x-ray of someone with a normal knee, a healthy knee, and one that has been diagnosed with OA. So you can see that there's a significant narrowing of the joint space. And in some cases, the x-rays will show the bone either freely moving through the joint space or the rough edges around the bone to indicate that there are bone spurs and changes to the actual joint itself. Other tests that they will do include MRIs and CT scans, and an MRI will show more of the soft tissue integrity. So that will reveal if in the knee, for example, you have any other meniscal damage or ligament damage to some of the main ligaments that we have in our knee that are also responsible for the support of our knee. So it could be that some of your symptoms might primarily be from the diagnosis of osteoarthritis, but some of the pain could be as a result of some of that tissue damage in there. Maybe the meniscus isn't absorbing the compressive forces anymore because over time that's worn out too. And that's something that would also need to be addressed going forward with either conservative treatment or surgical management. But that's something that, again, that your doctor will take a peek at just to rule out anything else that's going on or potentially going on within the joint. A CT scan or a bone scan aren't as common, but they do them sometimes if there's too much inflammation on the MRI. Sometimes it makes it difficult to actually see the images. So sometimes imaging is not totally accurate, and that's why they have to do multiple, more as a diagnosis than anything, just to kind of rule out and see what else is happening within the joint. So there's not one single test that is used to diagnose. It's typically a combination of these, especially with the conversation that you have with either your primary care doctor or your ortho or whoever it is that you're seeing for healthcare. So prevention. There are a lot of lifestyle changes that you can make to prevent your instance of developing hip and knee OA. Or it could slow the progression of the arthritis if you've already been formally diagnosed. So one of the biggest things is managing occupational risks. If you were in a job or are in a job that involves a lot of repetitive motion, you want to see if there's ways that you can modify that. So either a lot of bending or twisting or lifting or walking or moving in odd directions that you wouldn't normally do on a daily basis to complete whatever it is that your job needs you to do. Seeing if you can modify or change your body mechanics to work to your advantage so that way you're not placing abnormal stress on your joints. In terms of exercise, you want to have kind of a happy medium of exercise and rest. Our body hates the extremes. So we don't like the weekend warriors who are like, I think I'm going to go run a marathon this Saturday, but I haven't ran in probably all over a year. You know, our body doesn't like that. It also doesn't like being very, very sedentary for a long period of time because then that'll make daily tasks a lot more difficult, especially tasks that are like going up and down the stairs, sitting and standing, even just moving from bedroom to kitchen. Something as simple as that can be a lot more difficult if you're not doing the other activity to support and strengthen your muscles. So if you do exercise, maybe religiously, you might want to consider switching whatever activity it is from a high impact activity to a low impact activity. So maybe taking something from running and gearing it down to walking, or something like I play pickleball all day, every day a week. Maybe try going to every other day during the week, and supplementing that regimen with either a strength or flexibility program, something that kind of incorporates everything else to complement whatever it is that you're doing without placing undue stress on your joints. You want to minimize activities that aggravate your condition. So if stairs, aggravate your condition, try avoiding, excessive amounts of stairs. I don't like to tell people to avoid anything completely. I would rather try and find a modification first before trying to rid of any sort of activity, because that's important. That's why I'm here. Ultimately, to improve your quality of life and not take away from the things that genuinely you love to do. That's part of why I like my job, is I want you to be able to do as much as you can and love what you do pain-free, ideally. So always modify first. If even with modifications and you're like, I've modified everything, I can't really modify it, then that's time to either discuss with your primary or whoever your healthcare provider is, well, what's my next step to getting back? So rest is equally as important. Like I was just saying with exercise, that's important to maintain the healthiness of your joints and keep some of the lubrication of the joint fluid in there stimulated and healthy to move fluidly. It's just as important to balance that activity with rest. If you feel like you've done something and your joint's inflamed, there's a lot of pain, I normally recommend to people, well, take it easy for at least 12 hours. See how that feels. Don't try and push through the pain. Just take it easy, just for a day. See how you feel. If it's still very, very swollen and painful, then give it a 24 hours. Then gently add in some movement back to start to relieve the stiffness of your joints. Gentle movement will also help pump some of the swelling back into your lymphatic system, so that way it gets it out of that localized area. I think sleep is also an important thing to talk about. Making sure that you get enough sleep. Pain, it increases if you don't get enough rest. It's more of a psychosomatic effect because your brain can't process all of that at once, and it will send off alarm bells as pain. That's how your body's protective mechanism works. So even if you experience pain and you're like, I gotta back off everything, I can't do it, it's way too painful, you wanna just make sure that you're getting enough rest so that way your body can kind of process everything that's happening. It has to go through those motions. That's kind of the most annoying part of anyone dealing with pain, is sometimes you could do as much as you think you can to benefit it, but sometimes it just takes time. So don't feel like, I'm letting myself down, I can't do my exercises, or I can't get to pickleball today. Take it easy, rest, your body will thank you for it, for sure. Maintaining a healthy weight, this kind of falls along with our exercise, you want to make sure that you can take off any of the extra stress on the joint that may be deteriorating the cartilage. Any sort of weight in general will cause more compression within the joint space itself. So any kind of weight loss will help take off some of that added stress and relieve pain, and probably won't result in as much swelling or stiffness. Controlling blood sugar. I don't think that this is an obvious one, so I felt like this is an important thing to talk about. As I mentioned in the statistics, diabetes is one of, it's normally in combination with OA. 32% of people, or maybe it was 31, I better get my facts right. 31% of adults, or 47, I'm sorry, of adults with diabetes have arthritis. And this is because the high glucose levels in diabetes will speed up the formation of molecules that will make the cartilage stiff, but it can also trigger inflammation. So it may develop with an earlier onset of swelling, just in the fact that there's also coinciding diabetes alone, and that can accelerate the cartilage loss. So keeping diabetes or any other of your chronic conditions under management is important to do, not only for diabetics alone, but just to help regulate your glucose levels and either slow the process of developing OA or symptom management. So we will go on to some more symptom management. Now, this is when you're formally diagnosed with osteoarthritis and your symptoms are mild to moderate, but you're kind of wondering, well, what's my next step? What can I do without going to our last resort and hopefully no surgical treatment? Well, there's a lot of good things on here, which is the good news. So just by incorporating a couple or all of these things and implementing them into your life can make a huge, huge difference in pain and function overall, where you might be able to just manage your symptoms long enough on your own without having to see any sort of physical therapist, chiro, or ortho, or at least prolong the process of getting there. So the first one I listed is bracing or orthotics and assisted device use. So using things like ACE wraps. I'm sure a bunch of us have those floating around. I know I just moved to a new apartment and I still kept both of mine. So I was like, I know I'm gonna need these floating around here in the future. I'm not gonna get rid of these, so I'm taking these with my move. Got rid of a lot of clothes, but took my ACE bandages. But that will provide some support for the knee. There's several types of braces that you can use, and a lot of them are ones that you can find at like a Walgreens or CVS or just local pharmacy. And one of them is considered what we would call as a unloader brace. So that can shift the weight off of one spot of your joint and kind of center it a little bit more. So that will offload one of the affected portions of the knee joint itself. And another one is just a regular support brace, and that will just take off some of the load for you and kind of help you shift the weight away from having an entire body's weight on that one joint. Assistive devices, so canes, walkers, maybe even like a handheld crutch or something might be necessary every now and then. Maybe if you have what we'll call a flare-up, or when you have more inflammation and more pain, more stiffness and more swelling, that can also help offload the knee. So if you know, all right, I gotta go do my groceries, but I was playing tennis yesterday and I kind of flared things up a little bit. It might be a good idea if I just take something at least with me in the car, especially in weather and conditions like this. It might just be nice to have that to take off some of the support, or add to some of the support and take off some of the weight in the knee or the hip. Orthotics. So I talked about foot posturing before, and sometimes orthotics or inserts can be helpful in taking off pressure of a certain part of your joint. So like I was saying before, if your knee's having more of a tendency to kind of buckle inward, you have more pain on the inside of your knee, well, maybe just a little support might do the trick, enough to offload that pressure in that certain spot. It might be enough just to reduce any sort of flare-ups or instances where you have more swelling or pain. Heat and ice. One of my favorite things in the clinic, and I think it's one of my patients' things, I always say this is the only reason I keep people coming back. I always recommend to people to use heat to warm things up and ice afterwards to calm things down. Heat is going to loosen up the tissues and the muscles that surround the actual bony portions of your joint, whereas ice has more of a pain relieving effect. So it acts as an analgesic. So you would want to kind of follow up things with that. But I caution people with ice that you don't want to place on ice before you're about to go do kind of a heavy demanding task on your feet. Because you don't want to stiffen up everything and then ask it to get moved on, because then you're kind of going backwards with that, and that could end up in more pain. So when you know you're going to be kind of resting, sitting around on the couch for a little bit, or right before bed, that's when I would say ice is probably the most beneficial. I kind of already discussed this, but the regular physical activity, balance the activity with the amount of rest that you have, find the happy medium for you. Everyone's different. Your happy medium might be a little bit different than somebody else's happy medium, but it might take a couple of tries to see, okay, I could do this one day, but then take it easy this day. Or I could do 2 of these heavy things in a row and have a Christmas holiday, but then I know I'll need to take the other day to kind of calm things down a little bit. And I say days, but that could just be also hours too. You know, I know I have to do these errands, but I'm gonna at least, you know, meet up with Betty for coffee, so I know I'll be sitting for at least 20 minutes just to kind of give it a break before I go back out on my feet. Maintaining a healthy weight, like I said before, that's gonna reduce the load and the stress, and strengthening the muscles around the joint. So at the end of this, I have pictures of exercises that you can do that are specifically for the knee and the hip, that isolate the muscles differently than exercises that you would do on a day-to-day basis. So ultimately, that's what's going to build the strength the most. And so that is considered strengthening, as opposed to other exercises might be considered more cardiovascular focused or flexibility focused. I know you guys do chair yoga here, and that's probably focused on your flexibility, your core strength, your posture, your kind of body's control. Whereas other things, they're playing, what do you guys like to play? Throw something at me. Or activities that you like to do. You like to maybe take Fido on a walk on the trail, but it's on uneven surfaces. That what I would say is considered more cardiovascular health. You want to find the balance of something of each, a little bit of strengthening, something that has added resistance, whether it's bands or weights, and then also flexibility, so stretching and moving through your body's range of motion as best you can within the means that you have. Pharmacological management can also help. This is one of my least favorites, because I always think that, all right, let's resort to taking a pill, last resort. But it does help. Sometimes over-the-counter pain relievers or anti-inflammatories can help take off some of the pain that's caused by excessive motion. I'm going to go into that a little bit more later, because I think that one's an important one to talk about. But I think that's also very important to talk about with your primary care. A lot of times we're taking other things too, and everybody responds differently. You want to make sure that there's no drug interactions that are going to affect you in a negative way, or even in a harmful way. Injections can also help relieve some of your symptoms if they're a little bit more moderate. That's kind of the next step after you've taken all of these precautions. You've been using a cane and you've used a brace. You use heat and ice, and you've kind of done all of these other things, and you're like, yeah, no, none of this is helping. Sometimes your doctor will order a cortisone injection, which is a steroid injection into the joint space. And this will help take away the inflammation, swelling, and pain. that's not a permanent solution. That's kind of a Band-Aid for something, so that way, all right, let's get you through either the physical therapy, the strengthening, so that way you can kind of build up everything within a tolerable means and comfortably, and then once the effects of the injection wear off, then you can determine what your next step is. Because if it wears off and you're like, wow, my knee is so strong now, my hip is great, I'm moving normally, I don't really have any issues because I've done the strengthening work, that by the time the cortisone shot wore off, I kind of built myself my own body's brace, just based off the muscle and the tissue that are around the joint to keep it supported. Sometimes they will also do what's called viscosupplement, which is just like a gel-like fluid or gel-like substance that they'll put into the joint space, just to kind of keep the integrity of the fluid within the joint to keep things moving smoothly. That one is not as commonly used, but sometimes it's more appropriate for one person than others. Okay? Topical ointments or creams. Sometimes people have help with. I know some of my patients will use lidocaine patches and have great, excellent results with it. Other times I've had people who, they're like, yeah, I put it on, and it didn't really do much. Like I keep repeating, everyone's a little bit different. See what works for you. I always tell people, I'm not opposed to you trying something as long as it's not going to harm you or anyone else in any way. So if you said, oh, I rub regular lotion on it, and it helps my pain. I'd be like, great, keep applying that regular lotion on it. If that's helping, go for it. Like I said, just as long as it's not harmful to you anyway, then you consult with one of your primary care doctors. So moving on to conservative treatment. My favorite one, physical therapy. What? I don't hear a round of applause. So, your physical therapist will take a look at everything that I mentioned before. A lot of your body mechanics, how you're moving, your body's posture at rest, your body's posture with movement. They'll look at the integrity of the joint itself. There's a lot of special tests that you can do to rule out any other pathologies for anything that involves labrum, meniscus, ligaments, and some of the tendons that your muscles attach to the bone. And we'll develop an individualized program for you based off what your needs are and something to get you back to doing the things that you love. But it's personalized. These are all recommendations and management that generally everyone can take. But it's nice to have either your physical therapist, your chiropractor, or your orthopedist, or whoever it is that you've been seeing, develop something that's individual to you and what your needs are, and get you back to the lifestyle that you were used to before pain. Medications. So there are several types that can be useful in treating arthritis, but everyone responds to them differently, and you want to find one that's safe but effective for you. So over-the-counter pain relievers and anti-inflammatories are normally kind of the first line of defense in terms of medications. So for example, acetaminophen is a commonly known one that we use. But others can, cause other side effects if you're not paying attention to what else you're putting in your body. So just make sure to discuss any potential side effects with your doctor. I know I'm going to sound repetitive with that, but I can't stress it enough that that's something that you want to go over before you start to take something regularly. Another type of pain reliever is a non-steroidal anti-inflammatory, which is also called NSAIDs, as abbreviated. And these include things like ibuprofen and naproxen. These can be taken over the counter or by prescription, but I starred this one because I think these are ones that easily we can rely heavily on if we have pain. It's an easy thing. You don't have to like strap yourself up with any strap. You just take it, and a lot of times that will help. I stress this because there's research showing that there's increasingly negative side effects if taken in significant amounts. I think it's easy for us to do it. It's convenient, especially if we have other aches and pains too. It's like, cool. 3 birds with 1 stone. I just have to take 1 little pill and that will help. But the consistent use of it can be potentially harmful to your health. So again, that's an important one that I think we take probably sometimes on a daily basis. And that's something that you want to consult with your doctor about for sure. Cortisone injections, like I was saying before, these are the anti-inflammatory agents that are injected within the joint space. The primary goal of this is to reduce the inflammation, thus reduce the pain, and make things more manageable for you, whatever it is that you're trying to do, until you get to a point where, all right, I think there's nothing else I can do, and then you go to kind of last resort treatment. But I also have seen great success with cortisone injections. I've had people who have come in, gotten one, and been pain-free and totally fine and better mobility after them. But I've also seen the opposite, where it's only been like 2 days and they're like, I had a little bit of relief and then all the pain came back. So it depends. I wish I had a better answer than that. That's my least favorite response, but it's the most honest one. Everyone's a little bit different. You don't really know. A lot of times if you take an anti-inflammatory and that helps, that is significant enough to say that, okay, a cortisone shot would be a benefit, because that would be essentially doing the same thing as reducing the inflammation, just that kind of a little bit more of an aggressive manner. So glucosamine and chondroitin sulfate substances. So this glucosamine is found within the joint fluid itself. There's no evidence to support that supplementation with glucosamine is effective. However, certain people have subjectively reported that it helps them. So this kind of goes back to what I was saying before. If you apply that regular hand lotion and you put it on your knee and that helps pain, awesome. If you take glucosamine and you find that those supplements are helpful to your pain, go for it. As long as you and your doctor are in alignment with what you are taking and putting in your body, then that could be beneficial to some of you. I listed also some alternative therapies, such as acupuncture and not as popular magnetic pulse therapy. But acupuncture is a little bit different than dry needling. They're 2 separate things. So acupuncture uses what they call meridians. So it's certain landmarks in your body that are used to affect other parts of your body. That's out of my scope, so I can't speak too much of that. But I think if I could give an example, it's like if you have sinuses, I know that sometimes the meridian to affect your sinuses could be potentially on the bottom of your foot. Again, that could be totally not accurate. I just want to give an example, the difference between acupuncture and dry needling. And they use needles and they could put it in your foot, and in turn that could affect your sinuses. Whereas dry needling is still the use of those same acupuncture needles, but they actually insert it into the site that there is pain or tension or tissue restriction. So they use the same needles, but kind of a different method to address something that's similar. Some people have found that it's beneficial. Again, others have found that, nope, might have not done so much. So it's a trial and error, but it is an alternative method. And magnetic pulse therapy it's painless, but it's basically sending magnetic waves through a pulse into the joint space itself. So now surgical treatment. Now, Surgical treatment is reserved for those people who did not improve with conservative management. So once you have trialed all of these various ways and management, and none of them are successful, you felt like, all right, you know, it's been a couple of years, I was able to hold it off for the first couple of years, now it's just too painful, too debilitating, and if you're not able to find any relief with any of the aforementioned management strategies, then typically your doctor will refer to one of the following managements. So one is cartilage grafting, and this is when normal healthy cartilage is taken from one part of the knee or from a tissue bank, and they basically will fill in some of the damaged places of cartilage. This is typically for younger patients who have kind of the early stages of OA, when there's only a small portion of the cartilage that's damaged. And osteotomy is also used when the bony alignment is off, and it's used to realign the joint. So this is more of a temporary treatment. Again, kind of something else that can hold you off from getting a joint replacement down the line. So, for example, if you were to have an osteotomy of the knee, either your tibia, which is your shin bone, or your femur, which is your thigh bone, is cut and then reshaped to relieve pressure on the knee joint that may have happened as a result of some deformities that have developed over time. And the reason why we develop these bony abnormalities is, I think it's Wolff's Law, he refers to it as, but it basically says that bone grows in places where the most stress is. So basically that's the development of osteoarthritis, right? Where stress is placed. So these bone growths will develop just because of Wolff's Law, we'll say. There's your little science lesson. But basically an osteotomy is to address that. The last resort is an arthroplasty. So that is a total knee or total hip replacement. Sometimes they will do partial too if they think that's all that's necessary. A lot of times if there's other involvement with tissue damage, like I said, a lot of times we see it with meniscus or the ligaments in the knee, and they'll go in and basically clean up anything else that's going on, and they will take your arthritic joint and they will take it out, and you get to be a little bit bionic. They'll replace it with either plastic or a metal joint surface, and they basically give you a new knee or a new hip. But that ultimately will restore the function of your knee. Again, that's the very last resort, and that's only if conservative treatment fails. My clinic recently got pretty popular for knee joints. Whatever it is, things will come in waves, and recently we have seen a lot of knee joints. So they're one of my favorite. But of course, like we said, I've also seen a lot of people pre-operatively for that, where we've tried all of these conservative treatments, and when things are still too debilitating and you can't get through the end of your day without, excruciating pain, that's typically what your doctor will resort to. I printed out a list of some basic exercises that you guys can try or have as reference if you want to try, if you feel like you may have some of the symptoms or have diagnosed osteoarthritis. These ones, like I had mentioned, they're different than just regular walking or stuff that you would do throughout the day, because a lot of times we think, well, movement, right? That's got to be good for it. But these ones isolate things in certain positions that will take off stress from the joint, but also isolate muscles in ways that they don't get isolated on a daily basis. We move in a very forward society, and not often that we walk side to side for repetition, right? And a lot of times those are the muscles that we need strengthening, especially around the hip joint. So a lot of these are going to include isolation exercises. So our first one, this is what I was saying where we isolate the muscles. The first one is done by laying on your side. And this is going to help with your glute medius muscle, which is one of your gluteal muscles that lines the outside of the hip. This was important for not only the hip, but also the knee, because this is going to help with walking mechanics and alignment. So you're going to lie on your side. Whichever side is affected, you want the side up. I always recommend to people, if you're doing ones with the hip, to do on both sides. Because even if it's easier on one side, it's nicer to have them balanced than it is to just do one side and get that one super strength and maybe potentially develop wonky movements on the other side. So bottom knee can either be bent or straight. I prefer it to be bent just out of comfort. You're going to keep your top leg straight and try and lock out your knee. And then you're going to lift up towards the ceiling. Nice and controlled with all of your exercises. Okay? And this one adds up pretty quickly. A lot of these look super easy, but since they were working muscles in isolation, they don't get the help from the other bigger muscles that they're normally used to getting help from. So you want to make sure that your hip, knee, and ankle are all in one line. Okay? A lot of times we will hold our leg up in this position, we lift up, and we're like, yeah, not so bad. But that's also recruiting a lot of the muscles in the front of your hip. So we want to make sure that we're doing these. I'm a stickler for doing exercises. I'm nitpicky. All right? So you guys got to make me proud, okay? So our next one is a straight leg raise where you're lying on your back. You're going to take one knee. Again, I always say try it on both sides. Even if you have a great knee and it doesn't bother you, or a great hip, try it out and see what it feels like, because sometimes that gives you an indication of what the exercise should feel like, as opposed to what it may feel like with an affected body part, okay? You want to bend the other one, and that is to protect the back. It puts your back and pelvis in a more neutral position. You're going to tighten up your knee joint by straightening it out and trying to push it into the table or mat or floor or bed. And then you're going to lift up about opposite height of the other knee. And then slow and controlled on the way back down. So the slower you go, the more you're going to work your muscles. So a lot of times people see how many exercises I give them and they're like, oh God, I got to do this really, really, really quickly so that way I can get out of here and go to poker. So they're like this. And I'm like, no, you got to slow down. The more time your muscles spend under tension and doing work, the more beneficial it'll be and the stronger they will get. So even if we want to do them quickly and get them out of the way with, you're going to benefit more if you do them slow and in a controlled manner. Our next one is if you have a dog leash or a belt or a rope strap or even some extra resistance bands that are hanging around your house. And you're going to do a hamstring stretch. So the hamstrings are the muscles that lie on the back side of your leg, okay? Other leg can be bent or straight. You're going to take a strap and wrap it around the bottom of your foot, and you're going to pull your leg up until you feel a stretch on the muscles all on the back side of your leg, okay? You're going to hold for a little bit, and then you're going to give it a rest and perform that one 3 times. So I listed all of the parameters on here, how long you should be holding them, what the ideal frequency is. Again, this can be individualized. If you can only get through one set of it comfortably, then just stick with one set. You can always try for a second set the next time, or once your body gets adjusted to doing things in these certain directions. Our next one is bridging. This is one of my favorites, but this is also the most difficult one to do in your bed because it moves around a lot, okay? So this is the one that I tell people, still try doing it in your bed, even if you can't lift your hips up. If your hips are trying and your muscles are trying, they're still being strengthened in that way. So you're still gonna get a benefit from it, even if you're like, I feel like I'm flopping all over the place in my mattress. You're still gonna get the benefit of strengthening your muscles and trying to initiate the movement. So with this one, both knees are bent. Your back is flat on the floor.
You want your knees to be as far bent as they can comfortably with your feet underneath. Now, a lot of times, our range will only allow us to get to a certain point. Maybe here. Maybe this is as far as my knee joint can bend comfortably without pain. So stick within that range, okay? Don't try and push it just to make it look like the picture. Find what works for you. With a bridge, you're going to squeeze your glutes, squeeze the muscles on the back side of your hip, and push up off the mat, table, floor, bed, whatever it is that you're lying on. You're gonna wanna hold as long as you can, up to 5 seconds. And then slow and control lower back down, all right? Couple hold, lower back down. So if you're on the bed and you're like, this is as far as I go, my mattress is sinking in. Perfect, hold there, 5 seconds. Then lower back down. May not seem like much, but you're still doing work. The next one is a stretch. It shows it on the stomach. A lot of times that's not a comfortable position for most people. So you can find different ways that you could do the same thing without the use of a belt or a strap for this one. You could trial it standing, laying on your side. As long as you keep your knee, hip, and ankle joints similar to this picture, then you're still gonna get the same stretch, okay? Just whatever's comfortable position for you. So pictured, they have a gentleman laying on his stomach, and he has a strap wrapped around his ankle, and he's trying to bend his knee and pull it towards his hip. This is gonna stretch all of the muscles on the front of your thigh, okay? So I gave one for the back of the thigh and one for the front of the thigh. And a lot of times we think of those muscles being the ones that affect the knee joint the most, but it actually helps with the hip because one of your thigh muscles is actually one of the muscles that attaches to your hip. So you're kind of addressing both knee and hip with all of these exercises. And the last one is a sit to stand. So with this one, you're going to start standing or sitting, and you're basically going to sit down in your chair and stand all the way back up, okay? Now, a lot of times this is painful for the knee or the hip. Going through that full motion and that full range. So, like I'm a big fan of, modify, modify, modify. So you can use your hands and do the same thing. Take off some of the pressure and bring yourself back up. So you don't have to go all the way down to the chair. All right, see what works for you, okay? I always give the cue to people to try and keep your nose over your toes before you stand up. If I don't keep my nose over my toes, watch what happens. That was just a lot harder for me, and it probably didn't do great stuff for my back. So you want to think nose over toes as I sit down. It's going to make it a lot easier for you and a lot more mechanically friendly for your body. Okay? Sometimes it's helpful to start these with a higher chair or like a kitchen stool, as long as it's something that's not going to slide away from behind you. I like to just use the chair or a stool or something behind me as a cue. A lot of times mentally it just makes me feel a lot safer knowing that I have something behind me because my weight's supposed to be shifted in the backside of my heels. Yeah. Well, thank you. Thank you for listening to